As you can see, the patient is unable to move his eyes towards the right side. Pursuit movement is fine till the center and then it is affected. However, on further examination, you can note his dorsal eye movement, which is better. Now, the further examination, his convergence was normal. And to summarize our findings, we had a patient with a difficulty in moving his eyes towards the right gaze, with a slight deviation of eyes towards the left. There was no squint on nystagmus. There was absence of pursuits towards the right, and a normal dorsal eye movement and a normal convergence. At this point, I would open the case to the panel so that we could discuss a little bit and then further on move to the investigative part.
Any guesses on what?
From the audience, if there are any guesses, what was the possible lesion or location of the lesion? We have one who says that it's probably a medial longitudinal fasciculus injury.
I don't think that comes as a first choice. Medial longitudinal fasciculus is usually will cause adduction limitation with an abduction nystagmus in the other eye. What you are seeing here is a total gaze palsy to one side.
The convergence is preserved.
If it was MLF lesion, the adducting eye would be defective, but the abducting eye would show a full movement. Any other? I think whenever you see gaze palsies, you should think about pontine lesions, because gaze palsies elsewhere, like if it is in the cortex, will not sustain or remain for long. They are usually very transient. When you see permanent gaze palsies of this kind, more likely it is in the pontine area. So, Dr. Matthew, want to continue with that?
So, we had made a presumptive diagnosis. So, the diagnosis was a 30-year-old male with a right gaze palsy with a pontine lesion involving the parapontine reticular formation, or otherwise called the PPRF. We further investigated the patient, keeping this presumptive diagnosis in mind. We obtained his hemogram. His ESR was 56. His WBC count was 18,400. He had a positive manto. Other tests were effectively normal. His chest X-ray showed bilateral apical hilar shadows, as you can see in this picture on the right hand side. And further, we went ahead with the MRI. And in an MRI, we could find a well-marginated nodular lesion in the right paramedian pontine lesion. And for the contrast enhancement, we found that there is a ring enhancement of the lesion. And the radiologist had a presumptive diagnosis of tuberculoma in this patient. So, keeping this diagnosis in mind, we had given him anti-tubercular therapy, which was started immediately, and on follow-up, this was 1 month later on, you could see that his right gaze movements have improved. And on MRI, even the lesion size had decreased from 15 to 7 to 8 mm size. And this was his follow-up pursuit movements. You can see after the treatment, the lesion size has decreased and the PPRF involvement has almost completely resolved. Now, why did we localize the lesion? As ma'am had already pointed out, the patient was unable to see to the side of the affected lesion. That means there was a gaze defect actually. The horizontal gaze center was involved. He was unable to initiate the saccade to the same side, and his dorsal eye reflex was intact. If the dorsal eye reflex is intact, it shows that it is not a nuclear or infranuclear lesion. It's probably somewhere above that. So dorsal eye movement, what dorsal eye movement does is that actually vestibular nucleus, when the semicircular canals are stimulated, this vestibular nucleus stimulates the corresponding PPRF, and the same side 6th nerve and the other side 3rd nerve acts to move the eyes. So if the 3rd nerve and 6th nerve nucleus are fine, it should do fine. So that is why in this patient the dorsal eye movement was normal, but however the gaze was affected. The convergence was normal, as I had already shown. So keeping this in mind,
Just at this point, I'd like to say that it could also be a 6th
nerve nuclear involvement. If the 6th nerve nucleus is involved, then it does not present simply as an abduction deficit, but it presents as a gaze palsy, because there are two types of neurons present in the 6th nerve nucleus. One is the motor neurons, which are responsible for the abduction. That's why it will be a total gaze palsy. Now you move on to the second case.
The second case which I am presenting is a 37-year-old male who presented with a gradual diminution of vision in both eyes since 1 year. Patient was apparently normal till 1 year back when he experienced gradual diminution of vision in both eyes. He had no history of any pain, redness or photophobia, neither any history of trauma. There was a rapid progression of vision over the last 1.5 months when he had come to the RP center. There was no other known systemic illness. On confrontation and the questionnaire, he had revealed temporal visual field loss, and his visual acuity was 6/36 in the right eye and improving to 6/24 with a refraction, and the other eye was hand most close to face, which was not improving further. On examination, he had completely open angles. Pupils were there was apparent pupillary defect in both the eyes. The IOPs were in the normal range, 14 and 14. The disc margins were distinct. There was a cupping of around 0.6. There was a temporal pallor, suggestive of a partial optic atrophy. And this was a fundus picture of this patient. As you can see, there is a 0.6 cupping and the temporal pallor in these pictures, which are the color photographs which are shown above, and the other one is a red-free photograph, where you can note that there is a loss of the sheen of the retinal nerve fiber layer in this side and the macular area and the nasal area, where you can note in this patient, and similarly you can see a loss of sheen on this side. Now, patient was investigated further. This was a central corneal thickness. This was done on the OPD basis because seeing the cupping, the resident who was sitting in the OPD thought that the cupping could be because of the glaucoma. So he started evaluating the patient as a glaucoma patient. But definitely, the importance of presenting this case is that something else turned out. Now, this was the